Steve is a professor at Durham University in the UK. He has studied many of the important tropical diseases in Africa, in the Middle East, and in Asia, but an emphasis of his work has been on malaria. In fact, in the 1980s, he did one of the very first trials to demonstrate that insecticide-treated bed nets, which are an important tool in fighting malaria, was a exciting new way to try to reduce deaths due to malaria. He's also done some interesting work on house screening and other things, and he was, along with Willem Taken, the co-author of the Global Vector Control Response by the World Health Organization. This is a high-profile initiative that was recently unanimously passed at the World Health Assembly, and Steve played a key role in that. And so we thought, when we started thinking about the Sustainable Development Goals and how that could be leveraged, which was an important part of that report, that Steve would be the best person to come and talk to us about this. So, Steve, I'll turn it over to you.
Thanks very much, Tom. Can you hear me clearly, or?
Yes, we can hear you.
Yeah. Okay, good. I'm glad. I wouldn't want to speak to myself for the next 12 minutes in my office. Great. Well, thank you for allowing me the opportunity to talk to you today. And Sue-Ann, you have my first slide up, I presume.
Yes, the title slide's up.
Yeah, okay. So I'm going to talk to you about how we can use the SDGs to improve health, or particularly in urban health. And you guys very kindly sent me a small amount of homework. So if I could have the second slide, and asked me 3 questions. Firstly, about what are the global policy initiatives we could use to help improve infectious disease control. And secondly, how do we make this work? And thirdly, what's the evidence for this strategy, such a strategy working? So I'm going to start off, and next slide, by focusing on perhaps the big question: what do we use to leverage improve control of infectious diseases in urban settings? So next slide, slide 4, please. It occurred to me, well, before I start talking about control, let's think about what are the major infectious disease threats to urban environments. And in my book, the top of the list would be respiratory viruses, particularly pandemic flu, and SARS, and potentially unknown viruses. But a major concern of mine is the Aedes-borne diseases, dengue, Zika, chikungunya, yellow fever. For me, why that's so important is that people tend to compartmentalize this, where really what we're talking about is the vector. The vector is the best transmitter of arboviral diseases the world's ever seen, and its Aedes aegypti is an urban vector. So that's my concern, that people thinking about those group of diseases together, not separately. And then there may well be another group of suite of infectious diseases which are locally highly important, such as plague or malaria in India. So next slide, please. But I do want to just, if I may for a moment, just stress the importance of Aedes-borne diseases, because what we've seen around the world is this increase in dengue, which is predominantly an urban disease, and there'll be more of that in the future. Next slide, slide 6, please. So the distribution of Aedes aegypti in large human populations. So what you can see here is an illustration produced by Nick Golding, which shows in grey the distribution of Aedes aegypti, or at least the suitability of areas. That we are so ignorant about the true distribution of this mosquito, this fantastic vector of arboviruses. And the red spots represent cities with over 1 million people in them. And my biggest concern, or one of my biggest concerns, is about a disease like yellow fever moving out of Latin America or Africa into one of the mega cities in South America. How would we really control that? And for me, that's a huge potential threat. So next slide, slide 7. So we see the SDGs here are provide a reason for doing, because international documents are governed or helped by the SDGs. And if you press return, you'll see another arrow, which allows a lot of the international policies to be reorientated. And I'm going to give you an example of that later, which has happened with the control of vector-borne diseases. But I think it's also being soaked into our own psyche. If you press the final return to see the bottom arrow, that there is a cultural shift that people understand nowadays in academic communities, that to solve complex problems, you've got to go across disciplines and broaden your horizons. And so if you go to next slide, slide 8, that brings us directly to the SDGs. And to cut a long story short, I'm going to focus on the big 6, what I think are the big 6, important 6, that can help us with improving the control of infectious diseases. And I've ringed in red that SDG 11, which is about sustainable cities and communities. And this document, or the SDGs, are really forceful in helping us develop the global vector control response, which is my next slide, slide 9. So although we had in WHO a global strategy for dealing with vector-borne diseases, this is an interdisciplinary, multidisciplinary approach, which is called integrated vector management. That, plus the SDGs, and particularly the global pandemic of Zika, precipitated WHO to look again at global vector control to produce this, as Tom Scott has just said, this document produced and accepted by the World Health Assembly this year. Now, I'll return, if I can have the next slide, please. So, another illustration of how the SDGs help develop global health policy is SDG 11, which is about sustainable cities and communities, which gave birth, if you like, to the New Urban Agenda, which is about towns and cities developing strategies to become more resilient from threats of natural hazards. Now, most of the thinking within this field at the moment is focused on hazard threats like rising sea levels, earthquake. They really are not thinking about the threat from infectious diseases, even though there is mention of health and vector-borne diseases in the New Urban Agenda. So I think that's it, but I think there's an enormous potential here in which health can link with the group of people behind the New Urban Agenda. And if I could have the next slide, that's slide 11, just to give you a potted example of this. So we have SDG 11, which gives rise to the New Urban Agenda, and from that flows out another initiative, and I've put 2 initiatives here, the Global Alliance for Urban Crisis and the Rockefeller 100 Resilient Cities, which are opportunities for people in health to link in with people that looking again at resilience in specific cities. This is a huge opportunity because the people that run the cities are the mayors with huge power, finance, and facilities to make things happen. So these are precisely the people that we need to engage with. And I think for me the important message is that health should not be a separate strand, but we need to integrate with people that are already developing these ideas or looking for opportunities to do that. So slide 12 is well, okay, so how do we make this actually work in practice, and particularly down at the local level? How do we turn this from talk into action? So if you go to slide 13, as part of the global vector control response, we have this this temple of vector control here, and I've highlighted again with the red circles 2 important pillars of action that comes out of this policy paper. The first is strengthening inter and intersectoral collaboration, and secondly, the importance of engaging and mobilizing with communities. This is a real challenge. So if you go to the next slide, slide 14, this is a fussy slide, but work with me on this. So in order to make intersectoral committees work, you need commitment at the highest level, whether this is at national level or if we're talking about towns and cities, the mayor. Without the mayor's support and without finance, this is not going to happen. This is absolutely key for making, for turning policy into action. And what you can see here is an illustration of a type of committee that we could use for control of vector-borne diseases, where it's the health sector, but it's other agencies outside government ministries, in this case agriculture, finance and environment, etc., but also dealing with the private sector, community groups, NGOs, to get them around the table. So this will occur at the national level or city level, and if you press return, you'll see that can be broken down to regional and to local level as well. So if we go to slide 15, so what are we going to do? What are the magic tools that we have for control of vector-borne diseases, of controlling a major outbreak? So we have a set of tried and tested technologies, but what we're really talking about in the opportunities which are underexploited is not just the insecticide-treated bed nets, is not just indoor residual spraying, but slide 16 is to appreciate that environmental management, changing the way the cities are designed, is really important, because the immature stages of Aedes aegypti, the vector of these arboviruses, occur in water storage containers, used tires, solid waste, etc. So we can help build them out by providing reliable piped water so people don't store their water and provide aquatic habitats for the vector. We can remove tires, we can improve waste management. These in themselves are not going to solve the problem, but they're contributing to the overall way of controlling. They are an important part of controlling Aedes-borne diseases in the future. And by the way, it's what cities want to do anyhow to improve the living conditions of their citizens. So if we go to slide 17, I'm making the point that what's really important here is that we've got to break the mold of just doing the same old things within the health sector. This is about a bigger perspective, engaging communities and the non-health sector. This is health for all policies. It's not just about deploying tools. Slide 18. So what are the challenges? Well, the challenges here are we're going into the unknown. It's about establishing the intersectoral collaboration against the background of weak health systems. We don't know what intervention works, particularly against Aedes-borne diseases. They are neglected diseases, and the emphasis is on the word neglected, because we don't know what works. There's been a lack of investment in research into control methods. And there's also a big lack of monitoring and evaluation and research in this area, and we need to do better if we're going to seriously think about controlling these diseases. So that's how we can turn the policy into action. But if we go to slide 19, you say, well, what's the evidence for doing this? Show me where this works. And the only real example I can give you in slide 20 is the example from Khartoum in Sudan, where they managed to control malaria very successfully using their interdisciplinary approach. And you can see from this diagram the number of different environments that would be brought in to control malaria and remove breeding sites or aquatic habitats, I should say, in Khartoum. And if you look at slide 21, and you don't have to understand Arabic here, but this shows you the reduction in malaria cases over time that occurred by introducing that methodology. And then finally, I would like to summarize this in the last slide. So the points I want to make are that infectious diseases are a real growing threat to the health of people living in towns and cities, particularly Aedes-borne diseases. I don't think that threat is truly appreciated internationally. The SDGs provide a way, an opportunity for improving control of infectious diseases in urban settings. We must work outside the health sector. And I think the golden opportunity here is to link with those folk that are driving the new urban agenda, that are actually helping cities, city planners design the cities for the future, and are actively engaged in this process all over the world. Well, those cities and towns in urban, in tropical and subtropical regions need to be thinking about Aedes-borne diseases, and I would guess other infectious diseases as well. But how we're going to do this and how we're going to make this collaboration work, there are very few opportunities, and I think there's a real need to look at examples outside health to see whether we can learn from other organizations. And I think the key for making this work is intersectoral collaboration, and how to make those organizations work, how to make them sustainable is a major challenge. And the picture I put in the photo in this slide is the train leaving the station. Well, the train leaving the station is the new urban agenda. And I think there's opportunities for us to leap on the train before it's finally left the platform. Thank you for listening. And my final slide is really acknowledgements of the people that have helped support my work. So thanks for listening.
Looking at me. All right, Steve, thanks very much. That was a very nice presentation. Are we moving on?
I don't know if anybody has any questions for Steve.
Oh, okay. So yeah, we can take a couple of minutes for questions from forum members for Steve, if there are any. Remember to use your microphone and identify yourself. Jonna.
Good morning, Jonna Mazzette from University of California at Davis. I just wonder, building on your comment, Jim, about One Health earlier, and then the wonderful talk, bringing in those same concepts, both the integration of the environmental, human, and animal components, but also the second major tenet of One Health, the collaborative piece. And I just wonder, with the success in Sudan, can you point to how that was done, or do you have information on how those different sectors were brought together to address this issue that really built on success? Because it's a wonderful success story. It's something that we struggle in One Health to come up with really tangible success stories, and this one looks amazing. But I wonder how we tell that story or understand it better.
So thank you, Jonah. So a description of the cartoon project is written up in the IBM manual for sub-Saharan Africa. But if I can give you sort of edited highlights of how they managed to achieve that. So one, they had full political support for this and some budget, and they had a very effective and dynamic individual running this who powered the committees. But how they actually did it was they looked at where the aquatic habitats were, and a lot of them were relics of the poor British engineering that had been done in the past when they put pipes in which were now leaking. So they replaced the pipes so they no longer pooled. They went around and looked at where aquatic habitats were in the city, and many of them were being produced when one makes a building. In many parts of the world, you produce a pit for storing water. And so this is used for water for mixing concrete to make cement. But at the end, when the building is completed, you're meant to destroy that water supply, and people don't. So in Khartoum, they looked at their bylaws and they said, aha, this is against the law. So they went round and smashed them up because they had a local law that they enacted. They also had days when the agricultural fields around the city had to be free of water for at least 2 days a week, I think it was. And so originally they started to fine farmers if they didn't do that. And of course, as you can imagine, this caused absolute outrage and pandemonium But being Africa, that they got talking with the farmers, and they all agreed that this made a lot of sense in the end. So there was cooperation. They didn't need to find people. They engaged the schools in Khartoum, and they had a malaria day. And I think that every school child in Khartoum had to go out and find an aquatic habitat or a puddle of some description and fill it or treat it with insecticide. Now, I'm not sure how sustainable or effective that particular intervention is, but it's a fantastic way of getting the message across to people about and communicating with them. So that's just a few examples of different techniques and different groups of people from agricultural and engineering and public works that work together to make this happen. I mean, if I could also make a statement about One Health, I'm a great fan of One Health, but my vision is actually broader, because at least in the UK, when people talk about One Health, they talk about veterinary diseases or infections coming from domestic livestock to humans, whereas my vision is broader than that. I'm interested in what's spilling over from animal populations, and I mean wild animals, not just domesticated animals. And I think it's really important, and I know you folk in the States are heavily engaged in that, is that we have a better understanding of infectious disease dynamics in wild populations to better understand how we get spillover events into humans. I think this is a critical part of it. So my vision, I think, is slightly broader than perhaps most One Health concepts, or at least in this country.
Did you want to follow up?
Just a quick follow-up. Thank you.
And then David.
I share your broader vision for sure. Just the follow-up, and this is a really, practical point, but when we talk about implementing large-scale One Health projects, sometimes we get tied up in the practical human nature problem of in which ministries these things are headed up, and should it be through the Prime Minister's office, so that no ministry is more important than another ministry. And do you know where the sort of, you said full political support, but do you know how it was centered?
I don't know the
I can
details
do that
of that.
research, but yeah. Thank you so much.
Okay, David.
Thank you very much indeed. My name is David Nabarro, and I think my qualification for being in this group is that I've been involved in taking forward the Sustainable Development Agenda really since 2012, when the concept started to emerge. And I really enjoyed both the content and the style of your presentation, because of your emphasis on working outside the health sector, but recognizing that if you get it right, that will lead to health outcome benefits, and that they will be substantial. And so my comment on your presentation is that the way in which you describe the best options for doing this, using a multi-sectoral and interdisciplinary approach and engaging lots of different stakeholders, is exactly what was envisaged in the 2030 Agenda document when it was first produced. A universal approach, i.e. it applies anywhere in the world, an approach that involves interconnected thinking and action, that includes all sections of society during implementation, and that involves partnering as well as integrated action. And I would just like to suggest that as we conceptualize how to advance this way of working, let's be scared to go really wide in our thinking. Yes, the work for Aedes-borne arboviruses and other vector-borne diseases is a key part of it, but that could be linked to other activities, for example, for child nutrition, or for dealing with water and sanitation, without necessarily losing or weakening the emphasis on these particular arbovirus diseases. And I think that over time, we will find that this way of working, in line with the SDGs, will be available in many, many more urban settings. And it would be therefore relevant, I believe, and I'd like to know your view on this, Steve, to be careful not to constrain the thinking by, for example, saying, well, we've got to do vector-borne disease projects because that's what there's money for, or that's what matters the most to us, but instead that we should encourage these interdisciplinary and multi-stakeholder movements for health and seek ways to bolt in work on specific problems like the arboviruses to what might be a larger or differently shaped set of initiatives. And I pose that to you, Steve, to find out whether that is something that attracts you or whether you feel that a very special emphasis in the arboviruses and other vector-borne diseases is the way to go. Thank you.
So, thanks, David, for that kind review. So I think at heart I'm a public health person and a strong believer in the importance of clean water, sanitation, and improved housing, and recognizing that that has impact across a range of for infectious disease control and human health, improving nutrition and reducing respiratory diseases, etc. I think my concern, though, it's a bit like where we were in the 80s with village health workers, that you don't want to overload the system, and by making it impossible for committees to function. So I think it's fine that if we're talking here about urban centres, the urban centres consider what their priorities are. So there needs to be some prioritization, and that needs to be determined locally. So there's flexibility in that, but I don't think it would be useful to do everything, because you may make this a truly unwieldy system. And I think one of the points I'm trying to get across at the moment is not to oversell AIDS-borne diseases, but really for people to reflect and think about their situation in the urban centres and what they can do to reduce that risk. So I think that would be my take. So so bottom line then is I'm flexible, and of course you have to be locally appropriate to what the health problems are, but it's about not overloading, not making it the final straw on the camel's back. You have to have something which will work and not be overburdensome.
Okay. Thank you very much, Mark. I think we should move on. We're going to get behind. We need to save time for the breakout groups this morning. So again, thanks very much, Steve. I'll now pass the baton to Jason Corburn, who's going to moderate session 2.